Welcome to the Deep Dive, the show where we take stacks of technical sources, research, guidelines, clinical reviews, and distill them into the essential knowledge you need fast. Our mission today is a deep dive into the complex and I think often overlooked world of rehabilitation for breast and gynecologic oncology patients.
Yeah.
This conversation is really custom built for you, the medical learner or practicing clinician who needs a high-yield, structured roadmap to functional recovery and, optimal quality of life in this population.
That's exactly right. And we're moving beyond just a textbook summary here.
Right.
Our goal is to synthesize the foundational principles so you can immediately recognize what's going on and intervene. This entire deep dive is really built on understanding the clinical reality of functional decline, what the sources call the cascade of disability.
The cascade of disability. Okay.
And how adopting a proactive, comprehensive approach is, well, it's non-negotiable for improving patient outcomes.
Okay, so let's unpack this clinical roadmap. We'll start by establishing that core conceptual framework, the cascade and the prospective surveillance model.
Yes.
Then we'll move systematically through specific functional toxicities, from systemic issues like fatigue and neuropathy to regional concerns like shoulder dysfunction, AIMS, and the unique challenges faced by GYN cancer survivors, finishing up with some practical lifestyle interventions.
Sounds good.
So when we talk about functional decline in these survivors, the most important conceptual insight is this cascade of disability. It's a powerful model because it forces us to recognize that impairment isn't just a sudden event, but it's a layered, cumulative process. So the very real insight here is that functional decline starts long before the patient even enters the chemo suite. It's an additive risk.
Precisely. That's the key. If we wait for the toxicity from a layer 5 to show up, we've missed the chance to intervene on the 4 layers that came before it. This layered risk assessment is really the foundation of rehabilitation oncology.
So let's break that down. What are those 5 layers?
Okay, so the first layer is simply the baseline, age-related changes, the things that happen naturally. Think of sarcopenia or baseline muscle loss, and maybe some subtle peripheral nerve changes.
Just getting older.
Exactly. Then the second layer is coexisting medical conditions. This includes chronic diseases like diabetes mellitus, pre-existing cardiac disease, hypertension.
Why is this so critical?
Because cancer treatments can turn a manageable condition into a major functional crisis. For instance, a patient might have a mild pre-existing peripheral neuropathy from their diabetes. It's there, but it's manageable.
Okay.
Then they get hit with neurotoxic chemotherapy agents, and it worsens dramatically.
Right, and just pours gasoline on the fire.
That's a good way to put it. The third layer focuses on pre-existing musculoskeletal and anatomical conditions. Things like chronic back pain, adhesive capsulitis of the shoulder, pre-existing osteoarthritis, or baseline obesity. These are the mechanical weaknesses the patient is already bringing to the table. The fourth layer is the actual cancer characteristics. The tumor size, the necessary extent of the surgery, any lymph node involvement, or the presence of metastatic disease.
And the 5th layer is the one we always think about.
Yes. And finally, the 5th layer, the one most clinicians focus on, is the direct cancer treatment toxicities, the surgery causing shoulder dysfunction, the radiation leading to pelvic fibrosis, or the chemo resulting in cognitive impairment.
Wow.
You have to consider how all 5 of these layers interact to determine a patient's true functional status.
So understanding that complex layered baseline means that robust assessment is, well, it's non-negotiable. For a medical professional or learner, what are the key quantifiable assessment tools that the source material emphasizes must be done at baseline?
You need simple, reproducible, objective measures. For functional capacity, we look at the timed up and go test and the sit to stand test. These are quick metrics of lower body strength and fall risk.
Okay.
We also need grip strength measurements. If a patient is declining, these numbers will change, and we have the data to prove it.
And for things that aren't about strength.
Right. For objective measures, a peripheral neuropathy assessment requires testing muscle stretch reflexes and sensory input, specifically light touch and pinprick, to establish that sensory baseline before the first dose of a taxane.
Before. That's key.
It is, but perhaps the most non-negotiable baseline data point for many of these patients is circumferential measurements of the arms or legs. This baseline is essential for future lymphedema monitoring because if we wait until the limb is visibly swollen, we've missed the optimal window for early intervention.
That sets the stage perfectly for the crucial model of care designed to use this information proactively, the prospective surveillance model, or PSM. We used to just wait until patients broke down. What is this totally different proactive model really about?
The PSM is an evidence-based pathway that completely counters the traditional reactive model of just waiting for a complication to fully develop.
Right.
It insists on that detailed baseline assessment prior to treatment, but the real power of the PSM is the repeated interval assessment throughout the entire care continuum.
So you're checking in constantly.
Constantly and predictably. So if a patient starts a new, potentially neurotoxic chemotherapy cycle, or if they start adjuvant hormone therapy that's known to cause joint pain, you check their status again, proactively.
I see.
This structure enables the early identification of clinically meaningful changes and lets us introduce rehabilitation, prehab, or treatment before that functional decline becomes severe or, even worse, irreversible. This is the difference between catching lymphedema at stage 0 and trying to treat stage 2 disease.
Let's pivot from the care model to two of the most pervasive yet often invisible systemic toxicities: cancer-related fatigue, or CRF, and chemotherapy-induced peripheral neuropathy, CIPN. CRF is arguably the most common and debilitating symptom. For a busy clinician, what is the priority in approaching the assessment of CRF?
The priority is the exhaustive workup to rule out reversible causes. Fatigue is just so nonspecific, so you have to differentiate between true CRF and fatigue caused by some other underlying medical issue.
So a good history and physical.
Absolutely. That's mandatory. But the sources are also specific about the labs. Check a CMP, a CBC, a TSH, and an HbA1c.
Okay, but if a clinician only has time to order one or two crucial tests as a high-yield screen, which are the non-negotiable ones to quickly screen for those underlying medical contributors?
That's a great question. The CBC to rule out anemia and the TSH to rule out hypothyroidism. Those are fast, common, and often highly treatable causes of severe fatigue that are frequently missed in the rush of cancer care.
And once those reversible factors are addressed, what does the intervention look like?
The absolute first-line approach is non-pharmacologic. It starts with addressing potentially sedating medications. For instance, just reducing opioids and benzodiazepines, which are really common in this population, can substantially improve energy levels.
Okay, and beyond medication management.
On the non-pharmacologic side, physical activity is universally recommended. The sources specifically highlight yoga as a Category 1 intervention by the NCCN for CRF.
Yoga, interesting. Why yoga specifically?
Because it addresses both physical deconditioning and mood disturbance at the same time.
Okay, that makes sense. Moving to CIPN. This is a huge, long-term functional issue, especially for patients receiving taxanes or platinum agents. It feels like we are constantly trying to play catch-up with this toxicity.
We are. CIPN is devastating because it causes both loss of sensation and motor deficits. Functionally, this translates to gait dysfunction. We see shorter, slower steps, a reduced stride length.
Which means?
This means CIPN patients are 2 to 3 times more likely to fall, which can lead to fractures and hospitalizations. That is the practical implication you have to keep in mind.
So if we can't reliably prevent the neuropathy with pharmacologic agents, how does rehabilitation mitigate the functional risk? What's the high-yield clinical pearl here?
The sources are very clear on this. The single most beneficial non-pharmacologic intervention for CIPN is balance training.
Balance training.
Yes, involving both static, like standing still, and dynamic or moving movements. It's a functional compensation strategy. We are training the body to rely less on its compromised proprioception and more on visual input and core stability to preserve independence and drastically reduce that fall risk.
I was surprised to see how closely linked that physical dysfunction is to psychological distress. Distress screening sounds obvious, but what's one specific thing the NCCN distress thermometer catches that a busy oncologist might miss?
The distress thermometer standardizes screening for specific, actionable problems, so it quickly identifies issues like housing needs, transportation barriers, or unresolved spiritual distress, which often sit outside the typical medical discussion, but can significantly impact adherence and quality of life.
It's more than just a mood check.
Way more. And for effective interventions for that distress, structured mind-body practices show really strong evidence. The 8-week structured group program, Mindfulness-Based Stress Reduction, or MBSR, has specifically demonstrated that it can significantly reduce anxiety and depression in cancer survivors.
And that brings us to the necessity of integrated palliative care.
Absolutely. Palliative care should be initiated early, alongside active treatment, not just reserved for end of life. Integrating specialized symptom management earlier means we're addressing comprehensive distress and optimizing quality of life throughout the patient's entire journey.
We've addressed the systemic issues. Now let's transition to regional mechanical problems, starting with the shoulder, which is a major site of post-treatment functional limitation for breast cancer survivors.
Right. Shoulder dysfunction risk is highest following a mastectomy combined with an axillary lymph node dissection, or ALND. But, and this is important, patients undergoing breast-conserving surgery, or BCT, are definitely not exempt. Radiation to the breast tissue and axilla causes fibrosis, which restricts movement over time. For medical learners, here's a critical teaching point. It concerns reconstructive surgery. If a patient undergoes latissimus dorsi, or LD, flap reconstruction, they are associated with greater shoulder deficits, specifically reduced abduction, internal rotation, and adduction at 6 months post-surgery compared to other flap types.
So you need to be watching those patients more closely.
Exactly. This knowledge means heightened surveillance and very specific physical therapy are necessary for this subgroup.
That structural injury feeds directly into the effects of anti-hormonal treatment. Let's discuss aromatase inhibitor musculoskeletal syndrome, or AIMS. This is a massive issue in survivorship care.
It is a huge issue. AIMS presents as diffuse arthralgia, which is joint pain, myalgia, or muscle pain, and stiffness. It often mimics arthritis.
And what's the mechanism there?
The proposed etiology centers on the dramatic estrogen deprivation caused by AIs. Estrogen is known to have chondroprotective effects in the joints. By blocking estrogen production, AIs potentially contribute to joint degradation and pain amplification.
So what are the management strategies that practitioners must know?
They are very specific. For pain relief, the SNRI antidepressant duloxetine has shown clinically significant improvement, achieving a 30% decrease in average pain scores over 8 weeks in trials. That's a key non-opioid pharmaceutical tool to remember.
And what about the bones?
Right. We also have to manage the long-term skeletal risks. AI-associated bone loss is incredibly significant. It is 2 to 4 times greater than typical postmenopausal bone loss.
Wow, that's a lot.
It is. This is why aggressive prophylaxis is non-negotiable. Strategies like bisphosphonates, such as zoledronate and denosumab, are crucial and have proven highly effective in preventing this accelerated bone loss.
And finally, we should briefly mention the use of advanced pain techniques for those really refractory cases.
Yes, interventional pain management specialists can step in for chronic, localized issues. For patients with focal muscle spasms, sometimes called neuromyotonia, in transposed flaps like the pectoralis major, botulinum toxin injections have shown success in relaxing those muscles. This can also be applied to severe refractory neuropathic incisional pain.
Transitioning now to the unique challenges of GYN cancer survivors, focusing heavily on pelvic floor integrity. What does the data tell us about the prevalence of functional issues here?
What's sobering is the severity and prevalence. Pelvic floor dysfunctions, including urinary and fecal incontinence and significant sexual dysfunction, are reported to be up to 3 times more prevalent in GYN cancer survivors than in age-matched controls.
3 times.
3 times. Even those who have had benign hysterectomies. This is a massive burden on quality of life.
And the main driver is radiation.
The primary culprit is often pelvic radiation. Acute radiation effects usually resolve quickly, but the late effects, occurring months to years later, can include severe tissue damage. This manifests as vaginal stenosis, a shortening and narrowing dyspareunia, which is painful intercourse, and a high risk of pelvic insufficiency fractures.
So given these late effects, what is the critical practical counseling that every practitioner must provide to mitigate these long-term issues?
You must counsel patients on preventative measures, specifically the use of vaginal dilators. This needs to be a long-term commitment, about 10 minutes a day, 3 times per week, to physically prevent that stenosis from happening.
And it's not just about stenosis, is it?
No, you also need to preemptively address vaginal dryness. The Bartholin's glands are highly sensitive to low radiation doses and lose function quickly, so providing proactive education on vaginal moisturizers and personal lubricants is essential.
The other major regional sequela for GYN patients is lower extremity lymphedema, or LLL, which can be devastating to mobility.
LLL is a major risk, especially following the combination of lymphadenectomy and pelvic radiation. And while the standard management remains complete decongestive therapy, or CDT, which involves manual lymph drainage and compression, current evidence supports more active intervention.
What does that mean?
In patients with established stage 2 lymphedema, high-load active exercise combined with compression therapy, what they call AECT, significantly reduced lower limb volume compared to compression therapy alone.
So exercise isn't just an add-on.
Not at all. This is a strong call to action. Exercise is a core component of LLL management, not just an adjunct.
Let's wrap up with foundational lifestyle interventions, which are critical for long-term health. The sources noted that most breast and GYN cancer patients are overweight or obese at diagnosis.
And this matters profoundly for prognosis. For postmenopausal, estrogen receptor-positive breast cancer patients, obesity is associated with a 35 to 40% increased risk for recurrence and poorer survival outcomes.
Wow.
Weight management is a functional and an oncologic imperative.
So what are the specific nutritional guidelines that practitioners should convey to initiate controlled weight management?
For patients at a desirable weight, the goal is about 25 to 30 calories per kilogram for weight maintenance. But for overweight or obese patients where intentional controlled weight loss is the goal, the target should be 20 to 25 calories per kilogram. This range allows for safe weight loss up to 2 pounds per week without interfering with the energy levels they need for active treatment.
But adherence is always tough. The sources emphasize the use of motivational interviewing, or MI, describing it as a dance rather than a wrestling match. What does that mean practically for a clinician trying to help a patient lose weight?
It means moving away from a prescriptive, authoritative tone, you must do this.
Hi.
MI techniques focus on fostering patient autonomy and identifying their own internal motivations for change. So instead of telling a patient they must exercise, you ask them, how do you feel about the idea of walking for 15 minutes 3 times a week?
So you're collaborating.
Exactly. It involves listening, asking open-ended questions, and supporting their confidence. This strategy is clinically proven to improve adherence in this complex population where fatigue and other symptoms often derail behavioral goals.
And finally, a quick reiteration of the exercise recommendations from the guidelines.
The universal goal is to minimize sedentary behavior, which is defined as any waking activity with an energy expenditure of less than or equal to 1.5 METs. And the evidence base is strong here. Postmenopausal women on AI therapy, for example, adapt remarkably well to structured, combined aerobic and resistance training regimens.
And they see real results.
Oh, yes. They show measurable improvements in both body composition and strength, which directly combats the effects of AIMS.
This deep dive really emphasizes that functional capacity is not an afterthought, but an integral piece of oncology care that demands the same rigor as treating the tumor itself.
That's right.
Early, proactive identification, whether it's functional impairments like CIPN, musculoskeletal issues like AIMS, or late effects like pelvic floor dysfunction, is absolutely essential for maximizing quality of life.
It just highlights the necessity of integrated multidisciplinary care. The physiatrist, the rehabilitation therapist, the registered dietitian, the oncologist, they all have to work seamlessly under the umbrella of that prospective surveillance model. We are managing the layered, cumulative toxicity of the entire disease and treatment course, making sure the patient's functional life is prioritized.
That's a crucial mindset for any medical professional entering this field. Now, for our reinforcement exercise to cement this complex material.
Okay, let's do it. Imagine you have a postmenopausal breast cancer survivor receiving an aromatase inhibitor, or AI, who reports new onset bilateral knee pain and hand stiffness.
First, what is the probable syndrome described by these symptoms?
And second, identify 2 key non-surgical management or prophylactic strategies. One focused on managing musculoskeletal pain, and one related to long-term bone health, supported by the source material that you would recommend to her care team.
Think that through, and you've mastered the core concepts of AI toxicity management. Thank you for joining us for this essential discussion on rehabilitation and oncology.